So welcome everyone to today's webinar on return to work with chronic pain, medico-legal aspects. Returning to work with chronic pain is a major challenge in the workers' compensation system. Persistent pain affects individual productivity and causes major costs generally to society. Addressing this topic is crucial as improving return to work strategies results in better health outcomes for workers, reduces economic burdens, and of course encourages more supportive workplace environments. Providing advice in our IME reports regarding the work capacity of people claiming to have chronic pain is even more complicated. So we're very honoured to have Associate Professor Michael Vagg as our guest speaker tonight. He has an extensive background in pain management and rehabilitation, making him exceptionally qualified to address this critical topic. Michael was Dean of the Faculty of Pain Medicine and holds fellowships in both rehabilitation medicine and pain medicine, and as his current roles are Clinical Director of Rehabilitation and Pain Services at Epworth, Geelong, and also Director of Pain Matrix. Professor Vagg has a deep understanding of the complexities involved in chronic pain and its impact on work. We also welcome Sue Larson, Director of MEDirect, who's been a long time supporter of these AMLC webinars, Australian Medicolegal College webinars. The format of tonight's session is a little different from our usual webinars that we've put on previously, so I'm going to hand over to you, Sue, to advise how tonight's session will work. Thanks, Sue.
Thanks, Richard. So tonight I have got two simple but very crucial roles to play. First is to manage your questions, and second is to ensure that we wrap up in time for State of Origin kickoff at 8:05 p.m. So I can't stuff it up. So because we have a lot of valuable information to cover and time is going to be tight, I'm going to ask you to post your questions or comments in the question box as we go. There's a question box down the on the menu bar. You can put in Q&A. At the end of the presentation, we're going to use whatever time we have for the Q&A session. If we run out of time to answer your questions, don't worry, Associate Professor Vagg will touch base after the webinar to provide you with a response. So without any further ado, let's get started. Welcome, Michael, over to you.
Thanks, Sue, and thanks, Richard, for the introduction, and most especially thank you for the invitation, because I think this is an incredibly important area. As someone who has spent sort of most of my professional career looking after people with pain of one sort or another, and helping a lot of them back to work, including in a military environment, is something that it's given me a bit of understanding, and particularly I think I'm keen to share some of the really interesting new findings and new understandings that we have to enhance people's ability to give good advice in IMEs. Begin by greeting everyone. Kim Banebadi from Geelong in Warrawong country, and acknowledge any Indigenous First Nations people on the webinar tonight. In terms of disclosures, so I don't have any particularly, I wish I had some investments in research grants. As mentioned, Pain Matrix is our main practice. We have sites in a couple of sites in Melbourne, in Geelong and one in Melbourne. I work at Epworth, Geelong. I do WorkSafe Victoria IMEs for a different sort of company, and I've do a bit of teaching and otherwise representing Deakin Uni. I'm now a past dean of the faculty, and my new role for the faculty is as Director of Professional Affairs, which is best explained as a type of Hogwarts ghost who hangs around the college providing advice to the board and the executive, a way of monetising all the hours and hours of time that I've spent doing online meetings for the faculty. So I won't spend too much time because Richard nicely encapsulated the issues that we need to think about. And so these are some economic analysis done by Deloitte in 2016, and basically looks at the significant difference across the lifespan of people with persistent pain, up to 20% less likely to have employment, and they're more likely to lose extra time to sick leave. And when my patients are applying for DSP and I'm their treating doctor, it's often that requirement that they don't use excessive sick leave that is the problem. It's not so much that they couldn't turn up on any given day and do a shift. It's more that they can't do it consistently and they're constantly taking sick leave. And also the estimates for presenteeism where people are at work but not fully productive counts for about another 10% of the problem. And this is another point that's worth making as well, is that most of the productivity costs of having chronic pain and being out of the workforce actually fall directly on the worker. And predominantly that is because of reduced employment. And Fiona Blythe, who's a health economist, has estimated that the average person with chronic pain who leaves the workforce in their 30s or 40s will retire with a balance of $11,000 in superannuation if they're male and about $8,000 if they're female, compared to over $200,000 for the average worker when they retire. So, if it's a scam, it's the worst, lowest paying scam that you can possibly try and pull off, because it really doesn't pay very well, and most of the costs actually are borne by the workers themselves. So the latest figures we have is for 2018, and the economic cost of lost productivity was about 61 billion, and a further 66 billion in reduced qualities and well-being. The measurable direct cost to the health system was about $12 billion, and unfortunately, most of that's probably not very well spent, because regrettably we're still spending a lot on fairly low value care, and this is despite efforts of people like the Faculty of Pain Medicine and others to try and divert some of that spending towards more productive, better evidenced ways of doing things. So I'm going to start by just talking about a little bit in general about some of the newer findings and newer science that informs the way we look at things, and this is stuff that will lead to improved IMEs in the course of about the next half an hour or so, hopefully. So everybody should be pretty familiar, I think, with the flag system, and started out as red flags, looking at very important pathology that shouldn't be missed, and then progressed to clinical yellow flags, which are usually present in history, and then occupational blue flags and social and occupational black flags. And what's really interesting is that we've actually known a lot of this stuff for quite a while, and yet, so you could say we are kind of good at predicting using the flag system, but I would say we're only kind of good, because the actual degree to which the flag system predicts poor outcomes is debatable, and it certainly is very hard to generalize to an individual who's in front of you. So my first provocative statement for the evening will be that the biomedical details of the injury generally are maybe 5th or 6th in terms of importance in predicting which workers are going to progress to chronicity and which ones are going to have a good outcome with return to work. So, this is the bit that takes a bit to get your head around, because we're so used to thinking that it should be a pretty linear process, and in fact, our workers' comp systems are set up for a linear sort of process. And as I often say to patients, the system tends to deal well with people who are at either end of the spectrum. So people who have an injury which is fairly straightforward, generally has an anatomical basis that's easy to diagnose and manage, and has an uneventful trajectory towards the expected course of healing. It deals well with those people. It deals well with people at the other end of the spectrum who actually are catastrophically injured, and there's lifetime support available, there's lots of rehabilitation. But it's the people in the middle where most of the problems actually occur, because our systems are actually not particularly well set up to cater for people whose trajectory is not on the expected path, or people who seem to have not a lot of visible pathology, but a lot of visible disability. So one piece of the puzzle came from this fellow Vanya Apkarian. I was actually at the session in the World Congress of Pain in Milan when he presented these findings. And you don't have to actually understand what this means, but what Apkarian was saying is that using functional MRI measures of connectivity between the anterior cingulate cortex, the insula, and another. So the insular cortex is to do with assessing interoception. So it's scanning what's going on in the body, and the anterior cingulate cortex relates that to actionable things that the body can do, so motivated action. And then there's another area lower down which corresponds to the dopamine reward system. So what Apkarian and these guys were saying is that they reckon, using their protocol, that you can actually identify with over 80% accuracy within the first 6 weeks after someone's back is injured, who is going to still be out of work 12 months later, or who is going to progress to chronicity and who's not. And that's not even looking at the back, that's just looking at the brains of the people who have these problems. So this was, as you can see, this was published a while ago, and there has been more research on this area, but it hasn't quite been as straightforward as what Apkarian and the guys were hoping at the time. Another key paper a couple of years later was this paper by Vachon Presso, which again, I'm going to go straight to Professor Irene Tracy, who wrote the editorial. Irene Tracy, I had the pleasure of sitting next to at a Faculty of Pain Medicine dinner. She is now the Chancellor of Oxford University. At the time, she was just the head of department for functional imaging and pain research, but she's a super impressive lady. But this is her sort of takeaway from this imaging study, that chronic pain may be an attempt at an adaptive response that goes wrong because of a brain that isn't wired to do it right. And what's really interesting is that Irene Tracy and her colleagues would say that chronic pain is chronic virtually from day one. It's a seed. The inciting event is a seed falling into fertile ground, and that person is almost fated to have a bad outcome because of these issues that occur in their brain. So that's a very different way of considering chronic pain. And I'm also I'll talk a bit more about the school of thought who try to put across the view that all chronic pain is entirely a product of brain function, because I think that's equally as wrong as thinking that everything is driven from the bottom up. But where a lot of this variability, or what creates the vulnerability that they discovered in these studies, and it's actually largely to do with social and economic factors and some psychological factors that go a long way back in somebody's life. And so things like painful events in childhood, they don't have to be abuse or neglect. They can be just surgery or traumatizing injuries that occur to the child. But the thing that is the final common pathway for all these adverse events, what they create is a central nervous system that appears to have large numbers of activated glial cells compared to a normal person's, or someone who hasn't had those experiences. And we can, if you're interested, I can bore you the rest of the evening naming all the different ones that they've looked at and all the pathways. But what's really striking is that if you look at any adverse childhood event, present in about 70% of people with chronic pain versus fewer than 50% of the general population, and as you add them up, you add them together, they sum. So when something bad happens at some point in your life, the stress of that happening, the prolonged period of alertness of the central nervous system, for want of a better way of putting it, creates an environment where it seems to translate very easily to chronic pain if an appropriate injury happens. Or in the case of a condition like fibromyalgia syndrome, if something like a viral infection or routine elective surgery or something happens. So at this point, I'm just going to introduce the concept of a couple of different psychometric measures which are very helpful in the clinic at the bedside when you're assessing someone who has a chronic pain problem, and you're trying to get a bit of a handle on what are the most important psychological measures to look at. Because sure, everyone's got a story, everyone's life's been hard, but how do we know which are the people who are actually going to lead to trouble? So I don't know if anybody out there knows this particular comedian, but she's English, and in her little TikTok series, the brain is the character. She sort of anthropomorphizes different parts of her body in different situations, but the brain is always the one with the intrusive recollections and the anxious thoughts. And she'll be in a situation, and then the brain will say, "You're going to drop that right on your foot," and embarrass yourself and all sorts of things. So if you know who Hayley Morris is, you'll know who I'm talking about. But pain catastrophizing and pain self-efficacy are the two concepts that I'm going to briefly discuss today. They're related, but they're not the same, and they're somewhat misunderstood even within the pain world. Pain catastrophizing is what the Hayley Morris brain does. Pain self-efficacy, on the other hand, is more to do with people's sense of agency and how in control of a situation somebody feels, how much of what happens to that person they feel control over, and where is that, where is things going to come from to push them forward. And so this slide comes from a group in, I believe it's the UK. It's an NHS trust that has developed a quite a good online program specifically targeting pain self-efficacy. And what's interesting about both of these concepts, I mentioned pain catastrophizing and pain self-efficacy, but catastrophizing and self-efficacy are concepts that were borrowed from the early days of CBT. And they tend to, they're not very good slang, and we've tried to come up with a better name for catastrophizing, but we haven't managed it. The tool that we measure it by is the pain catastrophizing scale. It's been around for quite a while now, and it consists of a 13-question self-administered questionnaire with a total score of 52. If the patient returns a score of over 30, that is clinically relevant pain catastrophizing. And by clinically relevant, we mean if you ignore it, you're likely to get a worse outcome than if it is addressed. And pain catastrophizing maps to a wide range of adverse outcomes. But what's really interesting is that there was an attempt to, because you would think, okay, people who are malingering are going to have very high scores on the pain catastrophizing scale because they're going to exaggerate everything very deliberately. And there's some evidence that that's actually what happens. There was one study in particular that showed the very highest 10% of PCS scores, and that's scores of over 46, 47 out of 52. That's the point where you start to get some malingerers. It doesn't seem to be, the malingerers seem to go very hard to the right-hand side of the scale, and they don't actually give a lot of scores in the middle. So somewhere between 30 and 50 on a 52-point scale is likely to be genuine pain catastrophizing. Interestingly, this has proven to be such a useful scale, and the role of a significant other in someone's psychological adaptation to chronic pain is so important that Sullivan's colleagues and postgrads have actually developed a pain catastrophizing scale for spouses or significant others. And they've also demonstrated that that's quite a useful thing. They've also created a perceived injustice questionnaire because, as we'll come to in a minute, that's emerging as another separate indicator potentially of poor outcomes. But what's really important is that if you land someone in that 30 and above score on a PCS, you really ought to recommend that they have specialised pain psychology, because left unaddressed, it will significantly impair that person's attempts to get back to work. And it seems that the targeted treatment of that is far more effective than generic CBT. And I mentioned before that there's something special about chronic pain that creates catastrophizers, out of people who in other areas of their life are not they're not catastrophic thinkers. Sullivan, the guy who developed the questionnaire, said in a talk a few years ago that he believes he and some colleagues are closing in on a biomarker for high catastrophisers, similar to the way that Apkarian has looked at functional connectivity between the areas that he looked at. Sullivan and his colleagues believe that they're closing in on a sort of a biomarker for people who have pain catastrophising. So these are people who aren't necessarily the ones you would pick. There's not a great correlation between pain catastrophising and pre-existing anxiety, for example. So it's not just people who are anxious and catastrophic about everything. There appears to be something specific to pain. So what it needs is specialist pain psychology, because you get the best results with targeted CBT and targeted multidisciplinary teamwork. And if you want to learn more about pain catastrophising, I'd commend to you the work of Beth Darnell. Beth is a professor of anaesthesiology, perioperative and pain medicine at Stanford, which is pretty good for someone who's not a doctor. She's actually a psychologist. But Beth and her team developed an intervention called From Catastrophising to Recovery, or FCR, which is a 2-hour seminar which produces clinically relevant changes in pain catastrophising in chronic pain patients that last at least 6 months, which is pretty good for a 2-hour seminar. So she has a lot of YouTube videos that are still up about explaining pain catastrophising, how it works and what to do about it. The other thing that I'm going to talk about quickly is the pain self-efficacy questionnaire, which was developed in Sydney by Mike Nicholas, who's arguably Australia's preeminent pain psychologist for the last 20 odd years. So the PSEC is a 60-point scale, again, a self-administered questionnaire available for free so both the PCS and the PSEC form part of what we call the EPOC data set. So that's the standard it's binational between Australia and New Zealand data set for pain outcomes. So pain units who run multidisciplinary programs routinely collect this data, and we routinely use these questionnaires at intake in our private clinic as well, because it's so helpful to have an indication of what someone's self-efficacy is and what their catastrophising levels are before you even meet them. So a PSEC of over 40 generally is associated with a successful return to work. If you feel so hopeless and trapped and overwhelmed and like you can't do anything about it, you're actually going to struggle with your return to work. And we have routinely, we get people with single-digit PSEC scores, and you will certainly find them in IMEs. So scores of under 15, we wouldn't even put them in a pain group because they're not going to finish it. We would do individual work with them first to try and get that self-efficacy up and try and build it to the point where they have enough confidence in their own ability to actually do something, that what you then give them as self-management training will actually stick. So you can imagine if we're not going to put them in a pain group with a PSEC of under 15, they're really not going to do well with a return to work. But just on a lighter note, the lowest score that I ever got from someone rated himself minus 100 on every question, with a total score of minus 1,000. So you can get some fairly distressed and helpless patients. So how do we do it? Well, CBT techniques such as cognitive reframing, in other words, challenging a particular cognition that the patient has, and reframing it for them, teaching them how to monitor their thoughts and identify overly unrealistically low self-efficacy that bobs up in their thoughts, and challenging that with more realistic thinking. What's also really important, because self-efficacy to some degree is an unconscious process in the brain. So you can't necessarily think your way out of low self-efficacy. So it helps to be in a group and learn off other people, take those non-verbal cues and the group dynamic so that you actually do better from being in a group where others are having a crack and succeeding. So when we run our pain management groups, we generally keep them between 4 and 8 people per group, because less than that and there's not enough people to learn from. More than that, it becomes a bit unwieldy. The group dynamics can be a bit much. But somewhere between 4 and 8 is a good number, because people will be having diverse experiences. They learn off each other. They watch someone else having a go and succeeding, and it helps to bring up their own self-efficacy, because they start to believe that it can be possible. Individualised OT sessions can be particularly helpful at that practical problem solving, because again, if you've got someone who has really low self-efficacy, they just give up as soon as there's a challenge in front of them, because their experience has been that nothing's going to help their pain. They fail at everything, so why would I even try this? Or even worse, I could end up worse off because I'll just stuff it up anyway. So that's their self-talk. So if you've got OTs coaching them in social situations, coaching them in the workplace, and helping them to model good problem-solving behaviours, then that's how we go about managing sort of really low self-efficacy. And what's got to be really careful in designing treatment programs directed at low self-efficacy is you shouldn't send them out on a hopeless mission, because nothing erodes morale and motivation faster than realizing that the thing you're trying to do was actually never going to succeed in the first place. So you really have to scaffold these people very carefully, make sure that they are provided with experiences that enable them to start believing, and that they're actually going to, that it is up to them how things go. Just telling them to haul themselves up by the bootstraps doesn't really work. That tends to just reinforce the negative cognition that everybody else seems to know what they're doing and I don't, and that just reinforces their low self-efficacy. And this is a quote that we resort to very, very frequently in our pain management groups, that, up to this point, you've been problem solving, or you've been trying to manage your pain in the best way that you know how with the tools you've got, but you actually need better tools. And if you just think the same way, you're going to end up with more of the same outcomes. So challenging people to engage with behaviour change, to believe that it's possible, is a key part of raising self-efficacy and reducing catastrophising. So the first part of the answer is to, why it's hard to get people back to work, and how do we assess it? Well, a lot of the predictors of persistent pain risks and poor outcomes are not necessarily modifiable, because they're written in the person's genes and written in the person's nervous system, and they're not necessarily visible to an IME unless you actually use those tools that I've just mentioned to elucidate, a bit more of the complexity behind the people. And I wouldn't mind betting, in future, if you start using the PCS and the PSEC routinely, you will see that there is a spread of answers and there is a spread of scores, and the people who get the really low scores on both will be the people who your sixth sense that you've had via a lot of experience tells you that there's something not going to go well with this person. If they test well for PCS and PSEC, fine. Treat them like you would always treat everybody else. There's no marked adversity in their psychological profile that's going to hold them back. Okay, so this is just a different risk stratifying tool, if you like, that you can adapt. So some of the other things that we look at in pain management is that, as healthcare practitioners, you ask patients what they've had so far, or what's been done so far, and this is really important information as well, because often primary care practitioners or even secondary care practitioners are not actually doing some of the basics very well. So, and I probably don't need to be pointing a lot of this stuff out to this audience, but, something as simple as just, telling the patient when you would expect them to be back at work in the course of normal events, for example, as a GP, or, getting involved in recommending that the employer do something to manage a repetitive musculoskeletal injury is super simple. And as I've mentioned, Mike Nicholas's WISE study that was done a few years ago now, and yet we still don't have systematic funding to do it, because that study, which I used the Oswestry the Arebro questionnaire to identify high-risk people, risk stratify within the first 6 to 8 weeks of injury in primary care, and then have a flying squad of psychologists and experts, physios and OTs to get involved early on with the high-risk ones. You can't fund that under the current model. And although we know that it, in the WISE study, at least under ideal circumstances, produced stunning outcomes and unprecedented rates of case closure that people hadn't seen before, and yet it still isn't widely implemented. And when, as providers, we don't get funded to do it. So I'm going to talk a little bit about malingering at this point, and just spend a little bit of time reflecting on some of the definitions that are used, and maybe challenging a little bit people to reflect, is what you may consider to be malingering, or some of the metrics by which you might measure it, in fact, some of these pain phenomena, people with catastrophically low self-efficacy, people with extremely high catastrophizing scores, people with alterations of their nervous system function that lead to a heightened pain processing in the central nervous system. And a very good recent review from New Zealand was published in the Journal of Pain. It's a reference there. And what they do is actually go through a lot of the recommended screening tools that you could use as an IME, and essentially come to the conclusion that almost all of them, I think there might have been one measure, actually haven't been validated in a chronic pain population in a way which would allow you to actually distinguish reliably in a one-off IME whether someone was actually malingering or not, or at least what the risk of it was. So the challenge is to obviously you don't want to miss someone who's obviously malingering, but I think that's not the problem. I think those people are very easy to spot with the experience of the sort of people who are going to be dialing into this webinar. But it's the people where things don't seem quite right with the person, but there's no obvious reason why they would be. Their family needs them to work, they need to work, their self-esteem suffering, and they're showing high levels of distress. Then looking through that lens with the PCS and the PSEC may actually help identify some of these patients and lead to a more constructive formulation at the end of the IME, rather than just saying, oh, I think they're probably putting it on. Because in clinical experience, and this is that last paper, the Natalie Tuck one. Yep, this one here. So they actually make the point that in the chronic pain treatment population that we see in pain clinics, rates of malingering are actually quite low, because the malingerers don't come and they don't stay to pain clinics. So we actually see them, and if we have a bias in the chronic pain world, it's that we don't think anybody's malingering. So that has to be balanced against the fact that it's actually extremely difficult to assess it in an IME using the tools we currently have, because it will cause a lot of normal chronic pain phenomena to be misdiagnosed. So I don't have any straightforward answers to that, but that is it's an area of ongoing discussion, and it's a very helpful paper by Natalie Tuck and colleagues. I'd encourage everybody to sort of read it and get that perspective. Patients' beliefs are also extremely important in setting their level of anxiety about things. There is some degree of learning that they do about health behaviour, but overwhelmingly what the research shows is that healthcare practitioners are the main source of where patients get their belief about their problems from. And the framing that they get from their GP, from their osteopath or physio or chiro, whoever they see in primary care, they are likely to find that extremely trustworthy. I always find it's very helpful to see what they've been told about things, because they may have very inappropriate beliefs, but they didn't just come up with those beliefs. It was put in their head by somebody they saw who put things in a very scary or exaggerated way. And we actually have a list of words in our clinic when our pain fellow comes at the start of each year. We give them this list of words and we say, if we hear you using any of these words, you are fined a packet of Tim Tams on the spot. So you're not allowed to say things like bone on bone. You're not allowed to say something's the worst you've ever seen. You're not allowed to use the term disc bulging. You're not allowed to say that discs have either exploded, shattered, given way. All that sort of language actually is quite harmful for patients to hear. And in fact, Lorimer Mosley is somebody who has actually done or driven a lot of the research into the language about how we talk about persistent pain and body damage, and how important that is. And in fact, it was his group who identified that even just carrying out one imaging investigation in someone who has non-red flag back pain is responsible for about an extra 5 to 10% of worsening the outcome. So when people have a scan, it's validation to them if that something is being taken seriously, that something's being looked for. But the interpretation of that scan and what it means within the framework of what that person's being told about what's going on with them is incredibly important, not to leave that up to chance. So again, if I order a scan for a patient, which I don't do all that often, but if I do, I tell them what the purpose of the scan is. I tell them that, particularly if it's a back or a shoulder or a neck, I tell them that we're likely to see stuff on the report that doesn't matter, because by the time you're my age, in your mid-50s, more than half of us are going to have changes on a lumbar MRI, for example, that would sometimes be accused of causing pain, but only about 5 or 10% of those changes are actually going to be responsible for pain. So using non-threatening, language, Dr. McCoy, who's in the office next to me, likes to use the phrase, when he looks at people's backs and they say, oh, it's got this, it's got discs everywhere, it's riddled with arthritis, he'll just shrug and say, well, rusty gait will still swing. Because what we're talking about is the function. We're talking about, doesn't matter if it looks a bit ugly, if it's getting the job done, that's actually all you need to worry about. So the language that you use, and the language that people's treating practitioners have used, is a helpful thing to evaluate, I find, because sometimes people have been given really unhelpful advice or unhelpful, and a lot of it's unwitting, to be honest. A lot of GPs, primary care physios or osteos, they're not out to harm their patients. It's just that they don't know how important some of what they're saying actually is to the patient. And it hasn't been drawn to their attention that there might be more helpful, more neutral and less sort of catastrophization inducing ways of explaining things to people. So again, the practical takeaway from that. So we know that if you go to diagnose malingering, you need supporting evidence that you won't get just in the IME. You need to have other reports from GPs, from other treating specialists, or surveillance or other material that the insurance company provides. If you're worried that someone may have neuropathic pain, which causes the thresholds of various body tissues to shift their pain threshold, then you can identify that by doing pain-oriented clinical examination, which is really straightforward. Hang on, did we come off share screen?
Hang on a second. Yep. In a moment.
If I
Coming through.
That's all right.
Make sure up to you're up to.
I always hate it when the slides disappear.
There we go. It should be back. I think you're at that point.
Yeah, I was just about to raise the question, to draw people's attention to the YouTube video. So these were videos that we made with the National Prescribing Service, MedicineWise, a few years ago, when we were trying to do a campaign to get people to lay off the Lyrica and teach them to actually properly identify neuropathic pain so that you can target the use of the Lyrica specifically to neuropathic pain. So we have pain-oriented clinical exam. I think I need the remote control back, Sue.
Okay. A moment.
Much
Okay,
obliged.
should be good to go.
Yep, there we go. So there's not just, so there's pain catastrophizing and there's poor self-efficacy. Kinesiophobia is fear of movement, essentially. There's a scale for that, and we routinely use the DAS-21 to look at mood disorders and anxiety, because adjustment disorders obviously are very, very common, and they're a common obstacle to people being able to do better once the chronic pain is established. So being across those psychometric indicators will help you to evaluate things more accurately and give better advice, avoiding on the one hand the therapeutic nihilism of saying, it's chronic pain, this person's got no hope, they're just not, they're never going to get anywhere. And on the other hand, also saying there's nothing wrong with you, and the patient's going, but I can't go back to work. I've tried, I've had 4 goes, and every time the pain gets too much. So just because you can't find something on the scan, if you look with other lenses, you may well find other explanations that fit the picture better as to what's holding that person up. So, and then I'm going to just finish touching on a few system factors that feed into how I assess people as well. So this is a plain language summary that WorkSafe Victoria had to put out when they were looking at the finding of the Ombudsman, and it was pretty sobering reading. There's lots of easy headlines you can get by bashing insurance companies. So in some respects, it's not surprising that patients have some degree of distrust. And it does actually associate, so this issue of perceived injustice or inequity does correlate, you will see, to higher pain catastrophizing and more severe pain intensity. So that's why Sullivan and colleagues have developed a questionnaire which will sort of identify that separately. But the thing that I always ask, and again, I assess it. If I see that it's there, I'll give them the questionnaire and I'll say, just how much is dealing with the insurer doing your head in? Are you still angry at your old boss? Are you living your life in revenge for what's happened to you? Those are the sorts of cognitions that patients have, which are, again, phenomenally unhelpful at getting them to move on, but not always formally identified during an IME. So we haven't managed to get a perfect system by any stretch of the imagination, and I think part of my enthusiasm about being able to do the talk tonight is because I genuinely believe that if some of these very well established routine clinical assessments that we do in pain medicine clinically are incorporated into IMEs more routinely, we will actually better identify a group of patients who can still be helped and who actually are still good candidates for achieving a sustainable return to work. But we also need to advocate that our schemes do their part at enabling us to actually do that. So as I said, it's never the intention for workers to come out of the system with poorer outcomes, but there is some overlap between the risk factors, the way that people present, the adverse childhood events, those things. They may give the impression of symptom exaggeration, and if they elicit punitive responses from the system, that actually compounds the issue. So if you can identify these patients and say, no, hang on, there's not other evidence of malingering, and I have a catastrophizing score of 40 and this person's never seen an expert pain psychologist, then that's someone who you can still pull back from the brink, and that needs to be identified and fed into your IME outcomes. So again, I don't want to come across as though I'm saying that it's impossible to detect malingering and that it has, that we should never do it. I think everybody knows that that's not the case in any workers' comp system. There are some who, are trying to milk it, but we also have other explanations for how people can look distressed, trapped, hopeless within the system, but we have no other evidence or suspicion that they're malingering, and those people are worth looking at using a pain psychology lens, because you are likely to find that there's helpful recommendations that can be made there. So if we, and I'm going to scoot through this a bit because this isn't really an employer thing, but this is actually really interesting, that people reckon that their doctors are uniformly helpful, whether they make a durable, a non-durable, or no return to work. The variation in success appears to come at the employer's end. So we're arguing about this bit here, or we're beating ourselves up for not doing this bit very well, but there is a significant issue at the employer end as well. And that, the Faculty of Occupational Environmental Medicine, very commendably in my view, has initiated this Pays to Care initiative, which just makes these points in a very sensible and reasonable way, and gives businesses a way forward. But the slightly depressing thing that I'll get towards the end, is that until the employers actually decide to lift their game, it may not matter whether we're that good or not. So in the bigger picture, if you zoom right out again, the Faculty of Pain Medicine is a unique specialty internationally. There are other faculties of pain medicine in other countries, but most of them are exclusively related to anaesthesia, whereas the Australian New Zealand faculty, since it began, has been very multidisciplinary. We have psychiatrists, neurosurgeons, a handful of occupational doctors. We have radiation oncologists, gynecologists, lots of different doctors. But we need more pain specialists. There is a National Strategic Action Plan for Pain Management, which calls for increased training of non-specialist people to know how to manage pain, including a strategy for health practitioner education, which the faculty produced last year for the government, and they're now working on standards. In New Zealand, we've been asked to collaborate with the health department on a new model of care, and we also continue to try and work with insurers, enhancing the value of what we're doing. So we need, in my opinion, we need to do more early intervention. We need to actually have a systematic way of identifying people at scheme entry, at eligibility assessments, even to say, is this person at high risk or not? The ones who are at high risk, we need to intervene in an effective way. The Australian Pain Solutions Research Alliance is, I'll put in a plug for that because I'm on the board of it, but it's a large umbrella organisation which has probably 8 out of the top 10 pain researchers in the country are signed up to that. And it's a way of trying to enhance the translation of new research into systems level practice. And we're bidding for an MRFF grant to fund that. Incredibly important that we raise health literacy and get the employers on board, systematically implement new evidence. That's part of what I'm speaking about tonight, is to bring some of these newer ways of thinking about pain before a wider audience, and give everyone a big hug at the end. So I think IMEs can use some of these tools that we've discussed today reliably, identify pain cognitions which you may not have thought of before, but which you will find are there in a lot of the problem characters that come through your door. And more importantly, to make appropriate recommendations and actually be able to evaluate whether these workers have had a fair crack at effective pain management before we make any other recommendations. And the other thing is there will be some very interesting stuff coming along. There's a lot of very interesting research which is currently being done that we're awaiting the outcomes of, including potentially a blood test which can distinguish between nociceptive and neuropathic pain, which will be based on junk RNA in the bloodstream. So all this stuff is really exciting, and we'll certainly try and use them clinically as much as we can. So it's the wrong code for tonight to put this slide up, but anyway, being from Geelong, I have to put it up anyway. So we've got about 10 to 15 minutes or so for the questions, I think. Thanks, Sue.
Fantastic. Thanks, Mick. And look, there's been quite a lot of comments coming in, certainly being texted to me, and some questions that are on the Q&A. I'm not sure whether you can see the Q&A, Mick, but
at the moment,
you can't. That's right. You'll have to trust me then. But certainly a lot of, thank you for, can we get a copy of the slides? Yes, we've got a recording that will come. Absolutely happy to share a recording of the slides, and quite a few comments. So please feel free to add some questions as you come. Just in terms of the question around educational sessions, basically, and if the medical experts are doing a pretty good job, and where we're really falling down is around employers and other stakeholders. Have there been any moves to try and provide educational sessions to improve education and competency around this? And I guess the age-old question, who's going to pay? And I see Phil Sharp has already also put that. Who's going to pay?
Well, I think the thing is we're already paying. We're already paying for low-value care, and we're paying for a lot of low-value care. What we need to do is redirect some of what I don't think we need a lot of new money, to be honest. For every spinal neuromodulation system we don't implant, we could run probably 3 pain groups. For every spinal fusion we can avoid, because they all end up mostly having to do pain programs a few years down the track anyway. There's lots of evidence that we should be avoiding a lot of spinal surgery here in Victoria. Before a work cover spinal operation is approved, there has to be an IME that involves both a neurosurgeon and a pain specialist, which I think is a good initiative, because that's a way of getting in at that point of treatment where you can direct people who are appropriate for less invasive other types of treatment towards that treatment before looking at an expensive surgery that may be low value. So I think a lot of prescribing and a lot of currently provided care is fairly low value. So I actually think if we did it properly, it wouldn't actually be a net cost. It would actually be likely to be cheaper.
Yeah. So that you need a good lobbyist. Well, we need a fleet of good lobbyists. Fleet of lobbyists, that's right. Yeah, fantastic. There's been a couple of comments around, just listening to this and the biosocial or psychosocial aspect of pain. We've had one psychiatrist say that when he used to work with rehab and pain specialists in chronic pain, that almost 100% of pain is psychiatric, and basically referrals to psychiatrists were in order for chronic pain in so many of the occasions. I haven't done justice to that comment there, but basically just really reflecting on the psychological nature of chronic pain.
Yeah, look, and there's a whole huge conference you can have about the impact of psychology in chronic pain, and we have the faculty would all of our training units have to have at least psychologists and preferably psychiatrists involved in them, whether the psychiatrist is a faculty fellow or not. You need at least a consultation liaison psychiatrist. But the question is, what's the nature of what's the nature of the mental ill health, which is the chicken, which is the egg, and the concept of psychogenic pain really only still exists seriously in medico-legal circles, if I can be provocative. It's not a diagnosis that a psychiatrist or a pain specialist would make anymore, because the pain is an emergent experience of the brain. So some of the pain that you experience is created by events that go on elsewhere in the brain, in the assessment or the attribution of bodily feelings or bodily experiences. You can have issues with the nerve endings, for example, something like phantom pain. You have severe pain perceived in a body part that's potentially not even there. So there's a lot of complexity to how pain is produced, and the interaction of mental health with pain is something that we do week in, week out. We do see people with a lot of mental ill health, but it tends to be very predictable and related to the type of pain they have. And there are some patients, I will certainly say, where I've fixed their chronic pain by putting them on duloxetine. But duloxetine is an antidepressant, but it's only like a third line, not very good antidepressant. But it's a first line drug for enhancing descending pain inhibition. So, I think it's far too big a subject to talk a lot about in this sort of setting, because it's better actually when you have everyone in the room. There's a really good one that I see there about identical twin studies for chronic pain, and yes, there are. They show that there is a very strong heritable component to the susceptibility to chronic pain. So it's like a stress diathesis model. So you inherit a certain amount of risk of chronic pain, particularly neuropathic pain. And there are some patients who I've got where they're a walking encyclopedia of nerve pain. Every time they have an operation, they get nerve pain afterwards. They have shingles, they get postherpetic neuralgia, they get diabetes, they get peripheral neuropathy, they have cancer treatment, they get a peripheral neuropathy pain from the chemo. So there are some people who have an enhanced vulnerability to certain types of pain that is strongly genetic. But even other types of pain, there is an inherited component to it, and there are twin studies that support that idea, which is an excellent. It's a very good question. Sorry if I could I just want to pick a couple of good ones that I've seen. I haven't seen them all. But one about Keyser. So Keyser is a specific strength-based approach. I think it's really good for people who don't have abnormal pain signaling. The problem with back pain is that high levels of pain from the deep tissues in the back cause routine inhibition of deep muscles like the multifidus, forcing people to use their outer core muscles to stabilize. And the multifidus is not under voluntary control. That's the problem. And if you try and force an involuntary muscle to do something, you can't do it just by thinking about it. You have to force it into that position where it can be retrained. And even then, about 20 or 30% of them can't activate that muscle anymore. The brain just won't talk to it. So things like Keyser are very, very good at being able to isolate and target individual muscle imbalances, and to an extent help to reactivate things like the deep multifidus. So I do think it's actually a good way to do it. It's pretty expensive, but then again, so is a lot of stuff that doesn't work, like cannabis, which is a whole other webinar. But compared to something like cannabis, which is $400 or $500 a month, Keyser is pretty good value. It certainly gets better results.
So thank you for offering to do the next webinar on cannabis. We appreciate that, Richard, don't we? I'm really intrigued as well by the query or the comment from Michael Wren regarding his experiential involvement with Indigenous.
Yes,
who've had a lot of childhood trauma, but don't seem to have the same levels of
Yeah, and there's one of our senior fellows in the pain faculty, Matt Bryant, he makes the same type of observation that the cultural construct of disability due to low back pain seems absent in some Indigenous communities, and I'd offer my own experience in when I was in East Timor with in the early days after the referendum when I was in the military, and we would. Part of what my unit did was we were running one of the airfields, and when we had time, we would go out to the villages around the airfield and do little clinics and gather health information data that we could feed back to the NGOs that were coordinating the area. And apart from malaria, which about 90% of them had, back pain was the commonest thing that people reported to us. It was about 60% of them reported back pain. But the consequent disability to that back pain was not there. They still worked. They subsistence level. You had to work. So there is a lot of social learning, belief, expectation, and that's why CBT and these things can help, because they help people reconstruct a different experience of reality. And that is also where some of our systems force people to stay unwell if they're going to do things that make sense for them economically. Okay, so if you've got a 1 in 8 chance of going back to a workplace where there's bullying, and the alternative is to continue to be in pain, then you're probably going to take the pain. Because your brain will judge which of the two is
the worst,
is more survivable.
Yeah, and so, I think that also, like Tony Kays has raised a question, which I think is hand in glove with what you're talking about now, is the extent to that litigation contributes to increased catastrophizing and reduced self-sufficiency. Yeah,
I think it's really it's a complex answer, because the data would suggest that things like self-efficacy and, not so much catastrophizing, but certainly self-efficacy may be influenced by involvement in litigation. But my long clinical experience is actually the opposite. That I think litigation certainly increases people's stress and anxiety and their financial anxiety. And if they have a high sense of perceived injustice, they buy strongly into litigation. And I think that's the mechanism by which litigation worsens a lot of pain outcomes. I'm not aware of a study where they've drawn an exact parallel between involvement in litigation and being able to predict the degree to which someone catastrophizes. But you can see how it would happen. Yeah.
Couple of quick fire questions.
Yep.
How do you manage patients who lack the insight into the cause of their chronic pain?
Who lack insight? Yeah. The approved answer would be that you keep trying until they develop some insight. What actually happens in practice is if people don't like what we're buying, or correction, what we're selling, if they're not buying what we're selling, they drift off and they go and find someone who seems to meet their needs better. They end up coming back to us because we're in a regional area, and our clinic is, although it's a private one, we're essentially the only properly set up pain management service between Geelong and Adelaide. So we pretty much have a large area of people, and people do tend to keep coming back because everybody else, their treatment doesn't work. They can go off and have all these other treatments, but we actually have a pretty good idea how a lot of this stuff works, and going and spending money on ineffective or other treatments just because the person wants it, I guess is their right, and it's legal for people to sell them stuff that doesn't work, unfortunately. But I think it's difficult, and this is where we use a lot of motivational interviewing and that sort of those sort of strategies to really keep people buying into the fact that, you know, you don't, and behaviour change is hard, you know, getting your head around acceptance and learning and thinking differently about a pain that you've been living with for the last 10 years. It's not easy to do. It's at least as difficult as quitting smoking or losing 15% of your body weight. So you have to help people make those changes, and you have to use motivational interviewing and other strategies to try and keep them engaged and keep them coming back. And eventually, with some of them, the penny drops. Some of them, they don't have the psychological insight to complete a program or something like that. So you have to just fall back on medications and you know, procedures and keep them safe, harm minimise their use of health resources, and you know, empathise with them. Because it's an interesting concept. My psychologist said to me, you know, that pain psychology is funny, because he sees a lot of people who are years down the track from their chronic pain that still don't want to have pain. And he said, when people come to me for grief counselling, they don't expect to get their loved one back. What they want to do is they have to cope with this irreversible thing that's happened to them. And yet we still don't think about chronic pain quite the same way, whereas we probably should.
Fantastic. Last question, again, just a quick one, because the footy's calling. I can see the numbers starting to drop off, footy calls for the diehard New South Wales people. This is so complex. You know, everything you've talked about tonight and all the emerging research and where this is heading, you know, it's a very big and a very difficult concept. What are some recommendations that you would give to our audience if they have patients who've got chronic pain? Where do they start? What do they do? Give it 3 tips.
Well, I'd certainly say get to know, if there is a local pain service, get to know what it can do. Public hospital services are terribly constrained at the moment, but there may be accessible private services that do multidisciplinary pain in the best possible way. Try and avoid sending people for too many procedures if you're not seeing them build up into something sustainable. And most of all, you know, pay attention to the psychology side of it, because you know, you don't have to be a psychologist, but you do need to spot the people who will benefit from a psychologist.
Okay, fantastic. We're out of time. I know that there are a couple of people who put their hand up for an open mic. We might take that offline if that's okay. I'm just looking at the time, and I'll pass that through to Nick, who will give you both a call. I'm very happy to keep the conversation going by email afterwards. Fantastic. So thank you, everyone. Certainly it's in the next day or two. After tonight, no problem. Over to you, Richard.
Thanks very much. Michael, could we have the next slide, please? The last slide. Yeah, thank you. So this webinar is being recorded, by the way, so it'll be available free in the next few days on the websites of Australian Medicolegal College and of MEDirect as well. Australian Medicolegal College is a not-for-profit educational college with a training syllabus including many videos for trainee fellows at the college. We believe that continuous learning and professional development are essential to ensure that our IME reports are fair, objective, comprehensive and evidence-based, and we welcome your inquiries at the email which is on your screen now, ausmlcollege@gmail.com. That was just a bit of introduction. Michael, Professor Vagg, really thank you so much. This has been an extraordinary, thought-provoking presentation. There are a lot of questions still unanswered from the questioners that we have, and of course how we are going to utilise the extensive information you've given to us in our IME reports. You've given us a lot of key points and a lot more that we have to learn and read up about. The information and practical advice that you provided regarding work capacity of people claiming chronic pain will be very useful when attempting to address those thorny questions that are asked of us in our IME reports. So really thank you so much again. As always, a very special thanks to you, Sue, and to MEDirect for your excellent job in, first of all, preparing for tonight's webinar and then facilitating it, as always, in such a professional way, all the way through, using your skills as you've created this practice management system to support doctors in their medico-legal practices. And most importantly, everybody, thank you for your participation, your listening, and especially questions and we really look forward to seeing you at our future events, and have a great night and go the Blues. Thank you. Good night.
Thank you. Good night.